define how they're going to approach it. Physical examination, again, like we said, our abdominal girths here are not going to allow you to pick it up by manual palpation of the belly. It's extremely rare, or the person has to be very thin. Right. There are some pictures that you can see this kind of bulging thing, but usually if you look at the patient, he's cachectic. It looks like he had cancer or some sort. So it's extremely difficult to pick up by physical examination. What I do with my patients, if they are less then again, the aneurysm is got 3 centimeters when we start calling them an aneurysm, when they start getting dilated. I will start to treat them with a beta blocker or something to slow down the heart rate and get this pressure down as much as you can. Get them off cigarettes. It's one of the worst things they can do. Again, cigarettes, it's just the bane of society. Get them controlled, get their cholesterol controlled, get them evaluated, and then you have to do a program of monitoring. We usually, at least in our office, we tend to do CTAs every 6 months once they get over 4 centimeters. First, to monitor the size and the growth, because if you have a growth spurt of over 0.5 centimeter in 6 months, it means it's growing. It means we need to deal with this even before the threshold of 5.5 centimeters. So you have to do this on a very regular basis and keep an eye on these things. Again, patients don't need to get scared about it. You're treating, getting the pressure under control, and you're monitoring it closely. The time of rupture is when we get into the 5.5 centimeters. That's when you get to the higher risk of having the rupture. So by the time we hit 5 centimeters, you're going to visit Dr. Fail or yourself and start getting this thing repaired.
Right, Peter, in the last few years, CTA is clearly revolutionized, while CT scanning all along was the standard of diagnosis for aneurysms. As we got into the arena of endovascular aneurysm repair by the so-called minimally invasive method, CTA has grown in prominence. As somebody who is also heavily involved and passionate about CT angiography, where do you see this going?
You know, I absolutely agree. And you know, one of the other specialties that I've actually seen a lot is the back surgeons who get MRIs and this sort of far field view of an aortic aneurysm.
Correct.
But I think in the in the CT arena, and one of the things that we frequently get is a low resolution CT of a 5.5 or 6 centimeter aneurysm, and unfortunately a lot of times we have to repeat the CT. And I think the problem with that is that there is still this paradigm, if you will, that the CT is used for diagnosis. And although that's correct, you and I use it as a treatment strategy. And so we need to learn, we got to understand what we call the neck of the aneurysm, right below the kidneys, just before the aneurysm starts. What is that size? How big is it? How is there clot in it? How long is it? How big in diameter? We also have to understand the iliac arteries or access arteries coming up to the aneurysm. And when we have a low resolution CT, that becomes very, very difficult. And so there's frequently, we'll have a patient come into the office with a disc, a CT. You know, my doctor says I have a CAT scan. We look at the CAT scan, and unfortunately we can say, yes, you do, but I can't tell you if I can fix it now. I have to repeat the CAT scan. And so if I could behoove on the radiologist there, that although that, you know, it's important to make a diagnosis as an endovascular specialist, it really helps us if we have a high resolution CT on these aneurysms, really to find if we can fix it from an endovascular approach or not.
Correct. That's right. I mean, I do have some CTA images that in a moment, hopefully we'll get an opportunity to discuss that. And I also, again, want to remind our audience, this is a live call-in show. We welcome any questions pertaining to this discussion about abdominal aortic aneurysms or other cardiovascular topics. We'll take a small break here and come back again.
Even the very best heart care is of value only if you have access to it. So here's our pledge. If you have chest pains or symptoms of a heart attack, you'll be seen at any hour, day or night. If you don't have symptoms, but you or your doctor have concerns about your heart, you'll be seen within 48 hours. And even a routine heart check will normally be scheduled within a week. CIS is one of the largest, most advanced facilities in the South with an international reputation for treating heart disease. Call us to schedule your appointment.
I never thought it would happen to me.
I never thought it would happen to me. I didn't know women my age were at risk for heart disease.
Heart attacks are by far the most common cause of death in the United States of America. Many occur with no warning symptoms at all. Cardiovascular Institute of the South is the leader in treating cardiovascular and peripheral vascular disease. If you think you may be at risk of having a heart attack, Come see us at any one of our 11 locations.
Welcome to our live call-in show again from Cardiovascular Institute of South at Appaloosa General Hospital. Tonight's discussion is all you need to know about abdominal aortic aneurysm, both the diagnosis and treatment options. In the beginning of this show, between Dr. Fail, Dr. Arzola, and myself, we discussed about what abdominal aortic aneurysms are, and then we also went over who are the patients that are at high risk for abdominal aortic aneurysm, and then some of the diagnostic modalities of abdominal aortic aneurysm. We initially talked about ultrasound being a very simple, inexpensive way to diagnose it in the office when we find the patient has the right criteria for screening. And then once that screening is passed and when we diagnose that there is a large enough abdominal aortic aneurysm, means anything that is, typically ultrasounds are not super accurate in picking up. While they can pick up that the ultrasound is roughly about 3 centimeters or 4 centimeters, they do not delineate or outline in greater detail. So ultrasound may say it's 3, and aneurysm can be a tad smaller. Most times it ends up being larger. And so is the case with traditional angiography that we do in the cath labs as diagnostic procedure to detect blockages in the heart arteries. We can also diagnose an aneurysm during that. When we come by finishing an angiogram, it is customary for those of us who train together with you to do an aneurysm, to do a so-called drive-by shooting or a little angiogram of the aorta. And because most of our patients are about 60 or 70 years old by the time they are on the cath lab table, so they tend to be either smokers or have other cardiovascular risks. So it's a simple screening tool. We're probably expending another 10 cc, 15 cc of contrast. And if there is an aneurysm, we see an outline of the aneurysm. A lot of times we can actually pick up an aneurysm when the patient is on the table, and you have a heavy degree of tortuosity or winding of the aorta, and you can see the so-called eggshell calcification of the aorta. And shooting an angiogram, putting a pigtail catheter and shooting a little dye in there will give us a pretty good idea that there is or isn't an aneurysm. But all of us realize in the later stages that just shooting dye with a catheter in the cath lab is not the most accurate way to diagnose an aneurysm, because all we are showing by the traditional angiogram is the internal diameter of the aneurysm, whereas the one we are more bothered about as it comes to treatment is the external diameter of the aneurysm. Because once you shoot an angiogram, all you're seeing is the lumen. As the aneurysm bulges out in the abdominal aorta, there tends to be layers of clot kind of padding in the aneurysm. I wonder if it is a protective mechanism that God has created to some extent from the aneurysm seeing the pressure of the arterial pressure, which makes it susceptible to rupture. So the aneurysm gets kind of padded or lined with clot in layers, and what we call laminated thrombus in CT scan. So it's kind of a protective mechanism, but it can throw us off a little bit in diagnostic angiography in picking up the exact size of the aneurysm. So a CTA has certainly emerged, and that's where you were. And I want them to go and run a few CTAs while we are at it to just go over and show the audience a little depiction of what an aneurysm looks like. Here, Peter, you want to go over that slide there?
Here's a nice depiction. You can see at the 1 o'clock level there, that's the SMA, and then the renals are sort of putting out. But you see there's a nice size aneurysm. Probably I would guesstimate without calipers, probably around 4 centimeters, maybe a little bit smaller. But somewhere in the 4 centimeter range, got very, very nice iliacs. This would be somebody, like Fernando had said, we would follow this person, depending on the size, maybe get another CT scan in a year from now and see where they are. Abdominal pain, obviously, or quick growth would get them into the endovascular suite a little quicker. Yeah. There's a very nice, the next picture was a very nice representation. You can see there at the 9 o'clock level that very, very dark gray, and that basically shows you the clot. I mean, that's laminar clot that you can see laid in there. The light gray is actually what we would see in the angiovascular suite. So if we actually did an angiogram on this person, we would actually miss that inch or so of clot because we wouldn't see that very well. But you can see there's a very, very large aneurysm, got some calcification at the neck. Looks like the iliacs have fairly decent access. So this would be somebody, given the thing, I can't read the numbers there, but there you go, there's a nice crescent moon, and you can see that crescent, that's all the clot. And so this person, if they were a good candidate, obviously I think endovascular approach may be a good option for this person.
So I think that's where we are. We can go live now. We'll just talk about it and come back to this here.
What I found is, excuse me, my interruption, but what I found that the CTA offers the cardiologist that's evaluating this is the ability to move that by computerized images, so you can see this from all angles, which you can't do with the angiography. Traditional angiography you can't do.
Absolutely indispensable, as Dr. Arzola has pointed out, all of us in this business, once you come into planning the treatment, since, as Peter, that you pointed out, historically it was all surgery, so it was not necessary to see the aneurysm in such great detail by CT angiography when all you're thinking about is surgery. Whereas as it came to in the new era of the so-called endovascular exclusion, we are more preoccupied with the details of the neck length and the iliac diameters and all these things, because we need to insert these tools and get in there to exclude them. And talking about surgery, all of us have dealt with surgery for years in our training, and even now we still deal with them. I want you to highlight some of the, certainly surgery still remains to be an excellent procedure in suitable candidates. In this discussion, we'll try to focus a little bit on the non-invasive endovascular method, which are the more newer, more desirable approach for bulk of our patients, but still surgery remains a very reliable, effective procedure. But what are the pros and cons of surgery for abdominal aortic aneurysm?
Well, I think, obviously the surgical intervention, it's an invasive procedure. It's a very, very big procedure, a big abdominal incision. The big thing, just in an average aneurysm exclusion or repair, the big thing that patients wind up is being in the CCU for 4 to 5 days waiting for their gut to come back up. Because if you think about where the aneurysm is, it's actually behind the intestines. So as the surgeon makes that abdominal incision, he has to literally have to get the intestines out of the way. He's got to fix the aneurysm. He's got to put the intestines back in and get them to sort of settle. Intestines don't like doing that. They don't like to be messed with, so they basically go on strike for a couple of days. And so there's a lot of patients that wind up having a feeding tube in their nose, and they sit there waiting 3 or 4 or 5 days, waiting for their bowels to start. And that's pretty much the standard for most aneurysms. Now you start talking in men, obviously a 2-to-1 thing. There's a higher incidence of impotence in men in the open repair versus the endovascular repair. It's not a small surgery. Again, you always have the complications of a big vascular surgery. If the patient has heart disease, pulmonary disease, kidney disease, whatever, there's a lot of issues that go on with that. And I think, years ago, like I said, we did a lot of these patients that were not surgical candidates, and we took them to the endovascular suite, and that's shifted.
The paradigm has shifted.
So the patients now going to surgery either have anatomical issues that they cannot be done with an endograft, or they're much sicker than we're going to be able to do with an endograft.
Definitely. As you pointed out, if you want to tally these two things, surgery versus endografting, you're talking 5.5 days in the ICU, and the recovery time of probably about a week to 10 days or higher. And then after that, for all of us that have treated both bypass surgeries and aneurysm, open aneurysm repairs, all of us can say that aneurysm repairs are far more morbid on the patient.
Correct.
And needless to say, there are all kinds of other things that we need to worry about. Whenever they have aneurysms, we also need to worry that they have cardiac disease, and actually need to address that first, make sure that these patients are suitable candidates to undergo the open surgical repair, where they have to cross-clamp the aorta, causing problems with perfusion to the kidneys and perfusion to the lower extremities, worry about embolization, ICU time, cost, anesthesia, and it goes on and on, not to diss surgery, but it's just that is what has actually led to the emergence of endovascular procedures, and where Dr. Juan Parodi, the great Argentinian physician, who was the initial one who did somewhere about in 1990, started off along with Julio Palmas and other guys, did the first exclusion. That's paved the path for all of us to embrace this as an endovascular method. And all of us, initially it used to be the domain of vascular surgeons and cardiothoracic surgeons to perform an endovascular graft procedure. But now in the current world, it seems like all cardiovascular specialists, including radiologists, interventional cardiologists, vascular surgeons, and thoracic surgeons, all of us have done this effectively. And where do you, once you decide which the criteria can be technically a bit more belaboring for the lay people as to how we choose the aneurysm, but if you can simplify it as to when you will choose an aneurysm is good for surgery.